A small word about the history of the oral anticoagulants. In 1920, there was a sort of cattle's disease in the US. It was a severe bleeding diathesis in the cattle after eating what they called sweet clover. And it was actually, as you can see here, a very nice clover plant, Melilotus, but that produced a sort of toxin if it was moist and not fresh. And the toxin was then separated, and it was called dicumarol. That was the first name. And about 20 years later, the Lancet wrote that heparin had arrivals. These were then become the vitamin K antagonists because the action of the coumarins then were actually via the vitamin K pathway, PKA. And the pros of these products are that they have many decennia of experience and that the products are safe, effective, if there is a high time therapeutic range. So and then we were happy to welcome the earlier called the novel, but now the non-vitamin K oral anticoagulants, which we abbreviate with NOAC, or the same is actually the DOAC, and this is the direct oral anticoagulants. And it depends on whether it's American or European or cardiologic or thrombosis and hemostasis groups, then they call it NOACs or DOACs. We know by now that they are at least as safe and effective as the vitamin K antagonists. They have a shorter half-life. They are more predictable. We can use them in a fixed dose. There are no food interactions and fewer drug interactions, and there is no need for monitoring. So actually, quite a lot of positive points for these new drugs. If we look into the coagulation cascade, we all know that finally we target to have some fibrin to form a clot. And this is, we can become that clot by the means of the so-called coagulation cascade, which is triggered by factor 7A and tissue factor. Then we form a little bit of thrombin, and with an amplification phase via factor 11, we have a burst of thrombin generation. And in order to limit this clot formation, we have some parenteral drugs, the old heparin unfractionated, and then the newer low molecular weight heparins, but all these drugs have to be given intravenously. Oops. Do you still see my presentation?
Yes.
I don't see mine anymore. Okay, sorry. These are the intravenous or subcutaneous drugs. And then we have the oral drugs, as we said already, the vitamin K antagonist. In Belgium, it's Marevan, Marcumar, or Sintram. And these are they are indirectly inhibiting the vitamin K dependent factors, so 2, 10, 9, and 7, but it works via the vitamin K cyclus. And on the contrary, the DOACs are directly working on or factor 10A. We have 3 products, rivaroxaban, apixaban, or edoxaban, or directly on factor 2, which is dabigatran. If we go to the studies being performed with these drugs, and there are a lot of randomized controlled trials with a lot of patients involved, and we have actually 2 major subjects. There's on the one hand, the trials on atrial fibrillation with a meaning to prevent stroke or systemic embolism. And on the other hand, we had the venous thromboembolism trials. So I start with the AF trials. And on the top, you see the figure about efficacy, which means the prevention of stroke or systemic embolism. And this is here the 4 different products. So Rely was for dabigatran, Rocket for rivaroxaban, Aristotle for apixaban, and Engage for edoxaban. And here we can already appreciate that if we are on the line of one, well, then it's an equal effect for the DOAC or for the warfarin. But we see that the dots are all on the left side of the one of the equality axis eventually. So it means that they are at least as good. And we can see that there are some significant differences as well concerning efficacy, which is a good point. The under part of the figure is concerning the safety, and here is depicted the major bleeding. And there also we can see that the majority is on the left part of the axis and the one is just upon. We must not forget that these drugs have never been compared head to head. So we take them just apart. And if we try to pool the data, it's not a comparison between, but if we pool the data and we go to see to the efficacy on top and the safety down, then we can actually see two major things. That there is an enormous reduction of the risk of a hemorrhagic stroke or intracranial hemorrhage with these drugs. And on the other hand, that we have a slight increase in the gastrointestinal bleeding. And I will come back to that later on. If we just look then to the venous thromboembolism trials, then we have on top again concern the efficacy. So we have the first recurrent VTE or a related death. Here once again, we see the different trials with the different products, and here the combined results. It's less impressive than with the AFib trial. So on top, you see that the results are less impressive than with the AFib trials, but they are still tending to the favoring of the DOACs. And for the major bleeding, it's quite the same result. So after all these studies, we came to the final indications of the DOACs, which is first the primary prevention of deep vein thrombosis in major orthopedic surgery. And I say first because all these drugs start in these studies with the prevention in orthopedic surgery. But then come the important issues, that is the prevention of stroke and systemic embolism in atrial fibrillation, and then the treatment or prevention of secondary events in deep vein thrombosis or pulmonary embolism. And quite recently, there was another indication added for low-dose rivaroxaban in combination with aspirin in cases of secondary prevention of atherothrombotic complications in patients who have coronary artery disease or peripheral artery disease. Concerning the pharmacological properties, I told you already there is one product directly against factor 2 or thrombin, and there are 3 against factor 10. What is important in this table is that there is a short time to peak for these drugs. So there is a mean of about 2 hours. So if we take one of these pills, after 2 hours, we have already a correct effect, which is not the case with the vitamin K antagonists. And the half-life is also quite short, which is in the mean about 12 hours. And this has an advantage and disadvantage. The disadvantage is when the patient forgets to take a pill, then he doesn't have any effect anymore within 24 hours, I'd say. The advantage is that this drug is also correctly eliminated, and that in case of a bleeding or a problem, that if we can permit ourselves to wait, then the problem will be solved in itself. Concerning the renal excretion and the drug interaction, I'm coming to back to that later. And that's what we can see for the pharmacological properties. Here are the 4 different drugs. So the drug is taken orally, so it goes in the gut, is then absorbed on the gut, but is then actually resecreted. And the resecretion goes over a P-glycoprotein transporter. And many other drugs are P-glycoprotein transporters inhibitors or inducers. So you can imagine if we have a problem there, if we have interaction with other drugs, that the reuptake of our DOAC has a problem, that if you have an inducer of the PGP, then you will lower the drug concentrations in the and in the plasma, and that on the other hand, if you have lowering it, then it's the opposite. That's one way of changing the drug plasma concentration, so interaction with PGP drugs. And then we have the excretion or the metabolism of the drugs. We have the metabolism mainly through the liver or excretion through the kidneys. And for instance, you can see that here for dabigatran, there is a 80% renal excretion. So whenever we have there a problem at the level of the kidneys, there will be a problem for the excretion, and we have a higher concentration of the drug. On the other hand, we have differences in the hepatic clearance. For instance, for apixaban, 73%. So depend, you can see there is a high level of difference, 73 and 20 and 50 and 65. So while we have mainly about the same topic for the drug, so we target factor 10 for these three, there is a level of metabolism and renal excretion which is absolutely to take into concern. And there is an impact, of course, of renal and hepatic function. And as an example, I show you that the dosing is depending on the renal function. When you have persons with a normal renal function, and we take this as a clearance above 50 ml per minute, we have the normal dosing. If we go below that, we can see for a lot of drugs, we have to halve the dosing. These three and for these as well. For some, we come already in the orange that it might not be that good to use the drug, and then below 30 for dabigatran, it's not the intention to use it. For the other ones, we have to reduce. So for the renal function, we absolutely have to take these things into consideration. If we come then to the, if we don't give a correct dosing, we might tend to the more bleeding tendency. And the group of Thomas van Assen looked into that, and they took a total of the randomized controlled trials in AF. They had about 85,000 patients with about 5,000 bleeding events. And when you look here, and this is depicted here, the relative risk of a bleeding. So here you see the null axis, the zero axis. When you go below it, it means that there is a lower relative risk. So that means that it favors the DOAC. If it's above, it favors the warfarin. And for the different doses of the different drugs, you can see that they are all below the zero axis. So it means that there is a better effect, well, a lower tendency to do the bleeding there. And this, the last is here, the grouped. But if we look then into the organ-specific bleeding, it is quite different. And I first put your attention, I'd like to put your attention on the black square, where you see this is representation of the hemorrhagic stroke, which is impressively lower compared to warfarin. That's what we told already. But on the other hand, if you see here the blue square, it's for the gastrointestinal bleeding, and we can see there that they are mainly above the zero axis. So what could be an explanation for this effect? That is that actually warfarin goes not, it's not an oral, it's not taken into the gut, actually, it's actually metabolism immediately. So we have no active drug in the gut, while for our DOACs, we have always an active drug in the gut. And it depends on the type of DOAC, how many percentage of you have that goes in an inactive or active drug form in the gut. So the local activation of the drug by the gut esterases is an important point for dabigatran. And for the others, we can see that we have high doses versus reduced doses. As I said, you depending on the renal function. So there will be a different drug concentration. We have 2 of the 4 products taken once daily and the other twice daily. So there will be a difference in the local drug concentration. And what we have observed in the beginning is that actually in the older people, we had more gastrointestinal bleeds, and that might be explained that they have asymptomatic mucosal lesions that start to bleed when there is passing such an active drug anticoagulant in the gut. Concerning bleeding, everybody was quite puzzled that we had no antidote as for the vitamin K antagonist, where we have the 4-factor concentrate to give in bleeding. But quite quickly, we had the opportunity to have the antidote for Pradaxa, for that dabigatran, which is idarucizumab. It is actually a humanized antibody fragment directed against dabigatran. And it is given in an IV bolus, which completely reverses the anticoagulant effect of dabigatran within minutes. So this is quite practical for use in case of life-threatening bleeding or very urgent surgery. And then we are still awaiting the approval of a factor 10A inhibitor, andexanet alpha, which has been developed. It's a recombinant modified factor 10, but the administration is less elegant, I'd say, compared to Prexbine, because you have to give a bolus and then an infusion afterwards. And depending on whether it's, for instance, rivaroxaban or apixaban, these studies have been performed. The dose is different, and the time of infusion is different, or you have a peak again of your inhibitor. But it's still awaiting approval in our countries. And there is a third in development, actually, which is a quite strange molecule. It's called the synthetic small molecule, which would be directed against factor 2, factor 10, low molecular weight heparin, and fondaparinux, but the studies are still ongoing. One word about the laboratory issues. On the one hand, I told you already that there is no need for routine monitoring, which is a quite positive point for the DOACs. But on the other hand, we have the possibility to measure it in special indications. And this could be an unexpected thrombotic event while the patient is under DOAC, or a bleeding event or emergent procedure where you want to know, do I still have the drug on board? In a patient where we think that there might be chronically sub or supra-therapeutic drug levels. And for that, we have now the possibility in the lab to use the calibrated assays for the real quantification of the drug levels. We have it for anti-10A levels, and we have a dilute thrombin time for anti-2, which is quite comfortable. We don't ask it often, but it can be useful to do it. But when we have results there, we must be careful, because we have no established therapeutic ranges and we have no known correlation with the clinical outcome. So it's still difficult to have a good interpretation. What is important to know for the clinician is that the routine clotting assays, such as PTNR and APTT, do not reflect accurately the DOAC drug levels or the anticoagulant effect. So these are not meant. You don't look, if you have a patient just having taken his DOAC and afterwards you have a blood sampling and you have a high INR, it doesn't mean that your patient is over anticoagulated. So the degree of prolongation of these coagulation assays is highly dependent on which DOAC you are using, the time since last intake, and the reagent in the lab. And then what we have also to take into account is that there is an effect on the coagulation parameters. So even if you don't want how many drug you have on board, these DOACs affect the conventional tests. And for instance, if you ask a thrombophilia screening, you can have falsely normal results, for instance, for antithrombin and for APC resistance. On the other hand, for the dosage of coagulation factors, there is also an interference. So please take contact with the lab if you know your patient is taking a DOAC and you need, for instance, a thrombophilia screening. It's better to have first a contact. So I'm going to the end of my presentation. We can see a tailored treatment we can propose tailored treatment for the patients. So we have to choose the correct DOAC where we have no head-to-head comparison. We have to look at the correct indication against the bleeding risk. We have seen that there is an important drug interaction possible with the PGP inducers or inhibitors. The same goes for the cytochrome enzymes. And there is a good checklist, for instance, on the ERA guidelines to see whether there is an interference. And then on the other hand, if the patient is taking also antiplatelet agents, we have a double anticoagulation. And as I told you already, renal insufficiency, hepatic impairment, age, body weight has always have to take into the account and to check regularly. So for the last slide, I can say that there has been a lot of progress since the first study data. We know now that the real world data are reassuring. We have now the drug-specific calibrated assays, which can help us just in case of emergency. We have the development of already one specific antidote and probably next to come. And then we have the familiarity of the doctors to use the drug, which is already better than in the beginning. But I put the same thing also in the bottom as a limitation, because it is still not very easy to give the right drug, the right place, and the right dose. And we are still awaiting anti-10A reversal agents, and we have a lack of data in very specific disease groups. I think I'll leave it there.
Thank you very much, Christine. Excellent presentation.